which is extremely important at these times. So far, the focus of the international exchange has been much on the pandemic preparedness and response in medical, microbiological, epidemiological sense, and health financing has been less of a focus, but it is extremely important in how countries respond to, how countries pay for, how countries finance, and how countries affect truly the lives of their population in doing so and in allowing access. Therefore, we're very pleased to hear from South Korea and China, two countries that have been hit amongst the first ones and have already some months of experience in dealing with this issue. I would also like to thank the P4H network, who, as you know, are a diverse group of members of a network that is focused on health financing and coverage. Both of today's speakers are members of the entities that are, in fact, amongst the membership of the P4H network. The P4H network, as you know, has been in existence for over a decade and has evolved dynamically with the situation. And I think this is another opportunity for us to show that we are truly being very thoughtful and responsive at the times of great need for the populations that we serve. All of our institutions, and I know that there are many of the both institutions as well as academia and other members on these calls, and I think everyone in their capacities and our institutions are responding to this. You have probably seen in the World Bank, we have been working with all hands on deck on.
Now, without much further ado, let's move to the presentation of Professor Sun-Man Kwon. And you have received his short bio, so let me just repeat quickly outline. He's known, I think, to really many of us in this virtual room. He's professor and former dean of the School of Public Health at the Seoul National University in South Korea, and has held visiting positions at the Harvard School of Public Health, London School of Economics, University of Toronto, Peking University, and the University of Bremen. So he also worked at the Asian Development Bank and is founding director of the WHO Collaborating Center for Health Systems and Financing. But I understand he has returned back to academia. His CV is really impressive and long. For those who want more details, they can find it in the announcement. And for the sake of time, I would suggest that Sun-Man will start with his presentation. He can share the screen, and thanks again for coming, as I'm sure you're really busy with many international events of this type. Please, over to you, Sun-Man.
I'm very honored to join this webinar and share the experience of the Korean responses to COVID-19. And my presentation is mainly from a health systems perspective. First, let me start with a simple statistics. This is a accumulated number of confirmed cases. So this gray part shows that the total number of confirmed cases, the cumulative total number of confirmed cases. And then this one, dark blue bar, this shows those who are discharged, those are treated and discharged. And this part is the people who are in the quarantine. So you can see that it's a bit of plateau. So luckily, Korea seems to slow down the rapid growth in the number of confirmed cases. This is daily cases. So this blue line shows the daily confirmed cases. So there is a peak in the number of daily cases around the end of February, and since then there is a sharp decline. So these days we have about 5 to 10 new confirmed cases per day. And this part, gray part, shows the number of people who are treated and discharged. So overall, except for this spike in the late February and early March, I think we seem to control the cases. Actually, there's a big event here. We found a mass infection case in a big church. It's almost like a cult group. So we found a mass infection related to that church, which is located at the southeast part of Korea, so-called Daegu, Gyeongbuk region. So still now, out of the total confirmed cases, about half of the total confirmed cases in Korea is related to the mass infection in the church. So what are the major characteristics of the Korean response? I think the first, most importantly, is very rapid response, very rapid. And what is the main contributing factors? I think there's a good policy learning from the past. Korea has a outbreak of MERS, as Mediterranean. So the very important policy learning is from the Middle East respiratory syndrome in 2015. And I think at that time, Korea had one of the largest mortality from MERS outside of the Middle East. So after that, there is a series of reforms in the area of infectious disease prevention and control. For example, there is a huge strengthening of the Korean Center for Disease Control and Prevention, more budget, more personnel. And another very important part is this aggressive tracing of contacts. So Korea revised the law of infectious disease control, and we made an arrangement such that in a health crisis like this MERS or this corona, Ministry of Health and Welfare can override the private law. Actually, private law is very strong in Korea. So, but we provide a arrangement that the Ministry of Health and Welfare can intervene, and then there's a very aggressive contact tracing with the interview, with the credit card use and mobile phone location and information from CCTV. So all those informations are collected, and this is distributed to the public. Of course, I mean, there's no name, no gender, no age, but the public message sent by the district government to the residents about, okay, how many cases we have in this district, which restaurants the case visited, where, what type of public transportation, around what time. So this type of very aggressive contact tracing was made possible by the new law. There's a big social consensus because of this MERS crisis. And another, I think, issue is a test kit, also related to this MERS. So government quite swiftly approved for mass scale testing. So even in the very early February, at that time, there's only like less than 10 patients in Korea, but government approved the production. And then, and also after that, is drive-through, because there are so many tests. So drive-through testing or outdoor walk-through testing, that kind of kind of innovations are introduced to make it possible for the very rapid testing. And also this type of drive-through was very innovative because we can avoid the potential interaction of the personnel and healthcare facilities with this type of drive-through. And one of those advantages of rapid testing was the very early detection and isolation. And there's an issue, as you know, is the asymptomatic patients. Although they don't, even if they don't have symptoms, but they can infect others. So with this rapid mass-scale testing and isolation of positive cases, I think Korea successfully avoided the painful lockdowns, and we have a very minimum restrictions. No restaurants are closed, or no lockdowns, basically. Another one is also a learning by doing, I think, because with this mass scale of testing, we had a surge of cases tested positive. So initially, Korea hospitalized all those positive cases, and then, as you can imagine, there's an overload of the healthcare system with a shortage of beds for severe patients, severe COVID patients, severe other patients. So immediately, the triage system was introduced, and patients are prioritized based on their severity. So at that time, so-called, it's called residential treatment or living support centers were introduced. This is a kind of a transformation of existing big accommodation facilities owned by a big enterprise or some local government. So temporarily, it was converted into this type of living support residential treatment centers. And then they are, so milder patients were allocated to those facility centers, and they were examined and assessed by health personnel. Another very important issue is, I think, the governance. Also, during the MERS crisis, like 5 years ago, there's a heavy criticism that government did not disclose the information correctly to the public about how many patients, how many infections. So I think transparency in communication is very important, and contributing to the trust in the government, trust in the Korean Center for Disease Control, especially. And also, as you know, personal hygiene, like a face mask or hand washing, and also social distancing. These are the major, cost-effective responses, and these type of measures should be followed, should be based on the social capital and trust. So I think because people trust the government, trust the information provided by the Korean Center for Disease Control, I think people very voluntarily comply with the government recommendation. There's no enforcement, just the voluntary complied with the government recommendation. And it was related to a politics. I think we had the general election about 2 weeks ago, and that time there was a landslide victory of the ruling party, basically the party of this current president. And I think, I'm sure, and we all agree that this type of landslide victory of the ruling party resulted from a people's support for the performance of government policy in this COVID-19. And as a result, the conservative political party got the smallest number of seats in 30 years. Or, there's a very important and interesting thing about the interrelation between health and politics. Also, universal health coverage play also an important role to lower the financial barrier to access and organization of the healthcare delivery through a purchasing mechanism. Because we have a national health insurance system covering everybody, the cost of treatment is paid by the national health insurance system. And national NHI usually charges co-payment, but in the case of COVID-19, this is a communicable disease. So for the communicable disease, the co-payment for NHI is paid by the government budget. And also the cost of testing is readily available, and it is ex-ante free for those who travel abroad, for those who are exposed to contact with the cases, or for those who have doctor's prescriptions. And also, even without this type of conditions, but if the test result is positive, then it can be exposed free as well. And also recently, National Health Insurance in Korea introduced a exemption or discount of contribution for the vulnerable and all people affected by it. Purchasing issue is that one important characteristics of Korean NHI is it covers everybody. It covers all providers, and we have a unique ID like many countries yours. And one of the unique aspects of Korean system is a very private sector dominated system. Probably among OECD countries, Korea has the highest proportion of the private hospitals, like 90% of the hospitals are private. But all of those private hospitals and private facilities, private lab test facilities, they all join this national scheme. So this mobilization of private providers is a very important factor to respond to the surge of patients in late February and early March in that area with mass infection. Why? Because Korean system of purchasing is not contract basis. Actually, it's a legal mandate. All private providers should join NHI. So it has been quite controversial issue for private providers. Sometimes even Korean Medical Association owns appeal to the constitutional court whether this type of mandate without any opting out option is legitimate for the private sector. But this is the history. We have this is the case from the very beginning of the national health insurance, like 40 years ago when we first introduced public insurance. This mandatory mandate for the private hospitals was in. And under this COVID crisis, some hospitals are facing fiscal difficulties. So National Health Insurance Service provide advance payments. So before review and assessment, so pay first and review and assessment later. I think so. For many low and middle income countries, public financial management is quite important because we may need an emergency budget to provide necessary equipment and medicines, and also in case that health insurance faces fiscal difficulties, government also may also need some kind of emergency budget to support health insurance. I think it's how to mobilize these private providers in other countries. Probably contractual measure is not enough. So we may need some kind of a legal framework to mobilize private providers in a crisis situation like this. Health service delivery, as I mentioned earlier, we had allocated the patient based on severity. So severe patients are hospitalized, and milder patients, they stay in support and living support centers. And this is a paradox, I think, because Korean system, I don't think is an efficient system in terms of the number of beds per capita, because the number of beds per capita is the highest for Japan and second highest for Korea among all OECD countries. So this is quite inefficient system because we have too many beds. But paradoxically, too many beds have some flexibility to respond to the surge of patients. This is a question mark, but that's why I say just it's a paradox. Challenges. I mean, many other countries, like mother countries, the huge mortality comes from the elderly population. So same in Korea, we have the mass infection in long-term care facilities, nursing homes, geriatric hospitals, and also some big corporates, they voluntarily introduce a work from home program for like 2 or 3 weeks at the beginning. But the poor people or poor self-employed daily workers, they cannot enjoy this type of work from home. And also, there is in Korea, the older semester begins March the 1st, but universities open a bit later, but the primary school and the secondary school only open with 7 or 8 months is postponement of the beginning of the semester. So we are worried that this type of a delayed beginning of the semester, or now there's an internet-based classes, may have a differential impact on the student with different socioeconomic status. I mean, the gap between say, high-income family and low-income family students may become bigger under this type of internet-based classes. And although Korea were able to mobilize private hospitals, still, as you know, private hospitals do not have a very strong incentive to voluntarily invest in special wards and facilities for COVID patient or this type of infectious disease because it is low profit. So still, I think, although public-private partnership is important, but we still need a very strong public providers if we want to respond to this type of infectious disease or crisis. Mass testing, I think it worked quite well in the case of Korea, but still, I'm not sure whether this type of mass scale testing can be implemented in low and middle income countries because you need some infrastructure for lab personnel and facilities. So, and still some, is a minority view in Korea, but some scholars think that this type of mass testing and mass scale isolation of those positive cases, what is the impact for the potential herd immunity? And what is the impact for the potential second wave if Korea does not have enough herd immunity, although there's still controversy whether the herd immunity can exist for COVID. Some people say there's no antibody, and even if there's antibody, but it doesn't last long. So there are a lot of controversies, but still, although testing is quite well adopted in Korea, I don't know whether low and middle income countries can adopt this. Privacy issues, as I mentioned earlier, this type of aggressive tracing of contract is widely supported by the public, especially after this MERS crisis. But if other countries want to adopt it, it should be based on a social consensus. Otherwise, there's potential of abuse, I think. And also, Korea, there's a lot of discussions now about exit strategy. When or what sequence and what type of NPIs. So, for example, in the case of Korea, we never shut down public transportation, but in low-income countries, the shutdown of public transportation have a huge impact on the economy. So how and when to make this public transportation available will be a very important policy. I think finally, I'm currently involved in this government committee for the exit strategy, but because this COVID experience is so many people are scared about this COVID is a global disaster, pandemic. So most of the decision making seem to driven by medical expert in a sense. I think there are a lot of issues that we need to take into account, not only the medical concerns, like how many new patients, how many people died, but also broader perspective about the socioeconomic benefits and costs of various intervention measures. So I'm a strong proponent of that. This is kind of after the curve is flattened, we may need to view this COVID-19 as a social risk. Then our concern, our decision is that we need a value judgment. In other words, we need a good evidence, like the nature of the epidemic, benefits and costs, risks of various intervention measures. But this evidence will be provided by medical experts. But after that, we need some kind of value judgment to determine what is the optimum or acceptable level of risk we as a society can accept. This type of value judgment should be through some kind of some participatory decision making. Of course, I'm not saying we should use this type of participatory approach in an emergency situation, but once we succeeded, or once we pass the peak of the curve, then we should make a decision about exit strategy. In the exit strategy, you need to pay attention to this type of decision-making process. And like a school closes, when to open the school or when to close. we need a lot of value judgment and take into account all types of benefits and costs. What is the implication of the school closure on the care burden on families? So this is a bit long-term perspective. Thank you. This is the end of my presentation.
Thank you very much, Professor Sun-Man Kwon. Just for information for everyone, we have now 233 participants, which is truly impressive and which shows also the level of interest in this topic, also to learn from South Korea and China. Not only it's a truly global issue, but it also concerns us at different stages. So I think the countries really want to learn ahead of what has happened in certain countries. Now let's move to the next presentation of Professor Yingyao Chen. I encourage everyone to type down questions. Please, you may want also to look at the questions that have been typed down by participants. There were at least 6 questions which want to have more specific details. We'll give a Q&A session also at the end of this, but I will also promise that it's not only recorded, but we will type down the questions and answers and communicate it so that everyone's questions are being answered. So now let's move to Professor Yingyao Chen from the from the School of Public Health in Fudan University in China. A short introduction, and please find more details from the invitation. Professor Yingyao Chen is Professor of Health Services at the School of Public Health at the Fudan University. He's also Director of the Key Lab of Health Technology Assessment at the Fudan University and Director of WHO Collaborating Center for Health Technology and Assessment and Management. And he has written over 14 books and plenty of different academic papers, and also on issues of health economics. He has published 150 papers in Chinese and English. So we are really happy that such a qualified person has joined us and gives us insight in Chinese response to this. So without further ado, I would like to hand over to Professor Yingyao Chen.
Okay, thank you so much. And also great honor for me and to just present this presentation and to the P4H and their network. So my topic is the control and the prevention of COVID-19, the China response and the experiences. Okay, so I think we already know that the global COVID-19 pandemic actually just spread all over the world. So I think more than 3 million confirmed cases and 200,000 deaths. And at this moment, I think the health is at great challenging. And this moment, global health collaboration is the most important things. Okay, so that is the COVID-19 and China's just basic information. So actually that's just describe epidemic information. By April 26, totally accumulated and confirmed cases is 82,000 and total death cases is 4,600. So that's about 5.5%. That's fatality, and the total cure rate cases 77,000. And you can see total trace close contact person is 730,000, actually about 9 times and compared to the confirmed cases. So that means actually China doing a lot of epidemic investigation for those closely contact person. So that's the left finger just to show the trend of COVID-19. That's the new domestic confirmed cases in China. And that's the red bar is the new cases in China. And you can see that the blue bar is the new cases in Hubei provinces. So mainly it's the heavily affected by the COVID-19. So most of the cases actually from the Hubei provinces, And you can see that in the middle, and it's a kind of new cases quite high. That's because previous actually those diagnoses and based on the viral nucleic and acid test, but still have a lot of patient actually is under treated. So that's the guideline and the change, and also supplemented and by the CT scanner imaging. So that's why, and a lot of actually already have the CT scanner positive, and yeah, that's the test, and so also confirmed as the cases. So that is a big and a peak in the middle. So I think, and you can see the China actually the Hubei is the most and the series and the cases and the provinces, and in Hubei provinces, and so the total population is 60 million population, and in the capital that's the Wuhan, and about 10 million, and that's the population. So that's the basic epidemic information in China and Hubei and Wuhan. Okay, that's, and there's some features, and in China, and we have yeah, actually the first attacked by the COVID-19. So I also agree with Suman says that actually is the doing by learning. So that's kind of some information and the preliminary understanding of COVID-19, and that and the feature and that's sources from the WHO-China Joint Mission on COVID-19. So about 80% actually are mild and moderate and patient. 15% is a very serious, and 5% is critical. So for the case of fatality risk in Wuhan, about 6%, and actually the total is about 5.5, and in other region actually is quite low, and in other region about 0.8%. So that's actually also a significant different and in Hubei or Wuhan with other provinces. And the median time from onset to clinical recovery actually is 2 weeks. So that's, and also for the policy making, and why in the quarantine is the 2 week, and 3 to 6 weeks for some severe or critical cases. So that's the basic and the feature for the COVID-19, but actually we still haven't very fully and understanding of this virus. And the right side is just the effectiveness and the exist and combating against COVID-19. So that's the blue line, that's accumulated mortality, and so you can see at the end of the January is quite high. So that's actually is much and overload and pressure to the hospital in Wuhan, and then slowing down, and so basically is about 5%. But April 17, and actually the government and the health and the commissions and also double check those cases and including those deaths, and actually just double check after that is about 7.7% is the death rate, and that's a yellow bar means the accumulated is a cure rate. So that's about 92%. So that's just in Wuhan and the cities and the effectiveness. Okay, so I think the China response is quite quick, and I think the first I just would like to highlight is fully and quickly and the government commitment and the national emergency response actually according to the law was launched immediately and nationwide, and also the central leadership group for epidemic response and the joint prevention and control mechanism of the state council also established, and there also have the 9 working groups and the set up and to coordinate those kind of quick and emergency and health response, including coordination, epidemic prevention and control, and the medical treatment, research, public communication, foreign affairs, medical material supporting, life maintenance supplies, and their social and stability. And each working group and has the ministry and the minister levels, the leader, and so just leading that in the working group. And also the response was organized at the level of national level, provincial level, prefecture level, county and the district level, but also the grassroots community neighborhood level. So basically, it's kind of a unified and a very effective commanding and leading system. So that's the government commitment. And also government and allocate a lot of financial that's the money and to support that prevention and the control. So nationwide and different days and actually government have kind of just news the briefing media briefing and talk about those kind of financial allocation. So I just would like to highlight that by April 19, government at all levels have already allocated total 145 billion yuan and for epidemic prevention and control. So that's the yuan is 7 RMB yuan and equal to $1. And in Hubei provinces and the central government and allocate 6.2 billion yuan and for the epidemic prevention control in Hubei provinces, support medical treatment of patients, subsidize and for the medical staff, construction, new hospital, purchasing of medical equipment, and also the different kind of materials, and also public health epidemic preventions. So that's the government financial assistance and for the epidemic and also to Hubei provinces. Not just the financial support, but also the others, and including human resources, and there are also the other equipment. So you can see by March and the 1st, the total about total is 344 medical teams from different provinces and municipals, including 17 Chinese traditional medicine, and was dispatched and nationwide and to Hebei provinces. So totally is 42 medical staffs, including 11,000 doctors and 29,000 nurses. Actually, I think in Hubei and also Wuhan and the city, actually nurses is very lack of the nurses and the supporting. So a lot of other provinces supporting Hubei and Wuhan, a lot of nurses. Among them, I think most of those medical staff and were working the Wuhan. So the ESMO is also very important and equipment and to do the medical treatment and that's the Hubei provinces and estimate at the beginning of this the epidemic is just 20 ESMO in Hubei provinces. So then you can see and there's so increase very quickly and to the end of the February and the ESMO amounted to 113 and finally is 116 and most of them actually is government and coordinate and some is the important and that's the emergency and the purchase but also some and actually is just like a donation and from the NGO or other organizations. And also you can see the number of ventilator and in Hubei provinces. Actually, we don't know how many and they're existing and they're ventilator in Hubei, but you can see all the number actually increasing quick. And so the totally is the 24,000 ventilator and in Hubei provinces, also including some medical steam and just taking those ventilator and to Hubei or Wuhan. So that's just the financial and the human resources and also equipment and that's supporting. So The other thing is that I call that a classified medical treatment, and I think a similar Suman mentions the triage and prioritize and different kind of a patient. So you can see, and actually COVID-19 have a different kind of disease severity, and some are mild, some are very serious, and so that's maybe need a different kind of facility to support. And for those severe and critical and the cases need that's the ICU or very critical and intensive medical treatment. And mainly in Hubei, in Wuhan cities, and the healthcare capacity strengthening after the break and established the shattered hospital that actually is the previous the uses for gym or others, and actually just for quickly just refurnish and to the hospital, and they mainly for the mild and that patient, and all new constructed and two hospitals, and one hospital takes about 10 days and the other takes 18 days, and brand new constructed and communicable diseases, and that's a hospital totally is 2,600 beds, and also new furnished hospital. That's because previous hospital maybe mainly for those kind of diabetes or hypertension, those word, and should change to the communicable diseases and utilization. But also isolated facility by hotel training center totally is 530, and for those kind of isolated use, and the total beds and amounted to 110 and thousands beds. So that's in just in Wuhan cities. So just this kind of patient classification guidance, and left actually is the designated hospital, mainly for severe critical and suspected critical ill patient, and they have equipped a lot of ICU and unit or equipped the ESMO or others and high and tech equipment. In the middle, that's kind of a gym and just restructure and to the shuttle the hospital, and so you can right side all those kind of a shuttle hospital facility, and there's so mainly for the light and the ordinary patient and less and doctor, but still have and there's some nurses, and they're just kind of deviated and transmission and in the communities. Okay, this is the like um, clinical guideline and for the severe COVID-19 and the infection and pneumonia, and you can see and the pre-hospital assessment and melee and just triage the patient and at the different level and normal or heavy or critical, and in hospitalized, and so we have melee is a severe and critical ill patient, and so a lot of melee and intensive and supporting and in the hospital staffing equipment and a lot of things, and the holistic care including the Western medicine, also TCM and the supplementary, and they're supporting those and their patient. Finally is the just a discharge and back to the community, maybe go to the grassroots and community health center to rehabilitation. So those kind of guideline protocol actually experiences 6 revision and in just like 2 months. So that's actually a lot of revision. Actually is at the national level by the National Health Commission and also the Chinese Medical Associations. So that's like a treatment guideline. Okay, so then and there we will move to the prevention. Those prevention not just in the Hubei or Wuhan city, but actually nationwide and also like in Shanghai. And so that's our university based. So that's for early measure means and early detection, early reporting, early isolation, and early treatment. So I just very briefly talk about those 4 early. So early screening by temperature and the travel histories. So whatever and passing those kind of in the highway, or if we go to the like shopping mall or the supermarket and need a screening by temperature. And so yeah, and also we should end wearing the mask. And finally, and also we have the like APP and like we call the health code and show and your yeah, actually it's green, that means is healthy, and the red is means and have some yeah, alert. So that's kind of early screening. And also full coverage and traceability management for people contact with COVID-19. And the first stage mainly those people from Wuhan or from Hubei and move to other places, because at the end of the January actually is just Spring Festival stage, and a lot of people move and try to back their home and have their family together. So at the first stage and traceable and for that, and later on right now and mainly is traceable for those kind of just people and back from overseas. So that's, and also we use the big data and trace those kind of people, and there's so contact with the people, the patient. And there also the less social activity and early isolation for people with contact or symptoms, and less social activities. The Spring Festival, we always have family together and have the dinner together, a lot of social activity, but actually we just less those kind of social activity. And yeah, that's the other thing. And I think is very important to supporting the community or people is using the online shopping or online catering or online services, and also have the delivery and the person and the working and in the community, and just transfer those goods and the food and the materials. So that's, I think, is also important in China. And the treatment is mainly is a nucleic acid detection. And I know we have a lot of like research on that and compare different kind of companies, and that's a diagnostic tool and to test those kind of sensibility and specificity, and also CT scanner and the standard treatment. But right now, and also at this and the area also have a lot of drug and vaccine research and development and this stage, and try to have those kind of found yeah, that's the curable and the method and to control the COVID-19. Okay, then and there actually is a fully participant by the public and by the populations, and so mainly is keeping social and distance, and so that's we don't have a lot of yeah, we don't have a lot and the social activity at this stage, and also wearing mask. And I think that most of the Chinese people and wearing mask, and when they go out and to supermarket, to farmer market, to taking the metro or to the shopping area, and always wearing mask. Right now in Shanghai, I think 95% still and wearing masks, and they're also changing health behavior. You know, Chinese people have dinner, we always together share the cuisine, share the food, and right now, and we also have to use those kind of public chopsticks and just try to have better, and that's the health behavior. And also like yeah, reducing like smoking, those kind of a thing. Also yeah, in the community, the public also and participate a lot of volunteer services. And so you can see that the picture just like a volunteer just deliver those kind of vegetable and to the to the families and in Hubei, and also have a lot of volunteer and help to just guide the community and to do some of those kind of social services. And also in the public and the area, but also the community health center to do those kind of just sterilization and in the communities. So the other, I think, universal coverage, and in China, almost all people covered by the one kind of a medical scheme. But the different kind of schemes that benefit coverage are actually different. And I think urban employee are better, but farmer is it's not and so generous. And but that in this stage, actually, every and kind of a payment and covered by the medical insurance and the government subsidy. And so health insurance about paid 65% and 35% paid by the government subsidy. And according to the national data, that's by March and 15, and the average medical expenses for COVID-19 inpatient patient, that's the 17 and 1,000 yuan, and that's the money. And also give more just grantee, just new drugs that included in the coverage. So that's just a very simple. So maybe I just would like to summarize, and so China's solution may be implementation health in all policy, health and related to the other sector. That's very important, and also setting health as the priority. So balance and health and GDP and those, I think health more priority. And the other I already mentioned, national resources mobilization, classify medical treatment, prevention, public health, public engagement and involvement, and transparent context, and also multiple approach of financing government and medical insurance, not too much and like private sector, and also high tech research and applications. Next. So I just would like to say, just share this photo and taken in the Wuhan, and actually is Dr. Liu Kai from our university, Zhongshan Hospital, Fudan University, just accompanied the 87 years old patient to taking CT. After then, back to the ward, and the Dr. Liu asked the elderly, say, would you like to have more time to see the sunset? And the elderly said yes, and I haven't seen the sunshine a long time ago. So you can see just 27 years old Dr. Liu Kai, just with the 87 years old patient, just look at the sunset in Wuhan. Finally, and that 87 years old and also recover and back to home. So I think that's kind of warm and in this COVID-19 pandemic. And I think if we have the protecting health and saving lives as the mission, and we can work together and to achieve the global health goals. Oliver, thank you so much. A little bit over time.
Really well to the time. I mean, from the questions in the chat box, you see huge interest. And I mean, we will now have a round of discussions, and I would kindly like to ask you, Professor Yingyao Cheng, and you, Professor Sun-Man Kwon, to scroll while the discussants are talking through the questions and think which one you would like to answer first. As we want to focus on health financing, perhaps you want to look a bit more at the health financing questions, as many questions are really quite broad and in fact, probably going beyond the scope of a short discussion. However, also an announcement, we will share the presentations on the website of P4H.world. I've shared this website in the chat box. And also we'll try to address all questions that could not be answered in written. I mean, it's something I have to discuss with Professor Sun-Man Kwon and Professor Yingyao Chen to what extent they can get engaged in answering really all questions. Let's see. And now we are, by the way, 238 participants. And now let's move to the discussions. We are really glad to have, discussants being able to share their perspective from 3 different organizations, from WHO, from ILO, and from the Asian Development Bank. So I would like to invite Dr. Peter Cowley from the World Health Organization's Western Pacific Regional Office to start with his reflections on what he heard and to share perhaps WHO's point of view. And just also as a timekeeping arrangement, please stick to the around 5 minutes. Thank you. So please, Peter, the word is to you.
Thank you very much, and thank you to the presenters who were not only work colleagues but also friends. Firstly, from the Western Pacific Regional Office perspective, we're using the experiences in Korea and in China, and we're exporting them to other countries. And we know that the governments of Korea and China are also active in sharing the lessons learned in their response to other countries in the region and abroad. So it's rapidly becoming an export industry for both Korea and Japan. A part of the what we know from the response in Korea and China is applicable to other countries. Part of it is not. Some of the reasons why the applicability can are around the political economic context. We know that there is a strong social contract in both China and in Korea. We know the government is trusted. We also know that they have faith in their public health agencies. Other countries are not so fortunate in terms of the strength of public health agencies. Other countries as well were not so exposed to previous epidemics such as MERS or SARS, so they didn't have the demand to build up their public health capacity. Again, for many countries in the Western Pacific region, this is not the first time. This is fairly severe this time, but there have been other epidemics in which they have had to address. And so learned from that. A lot of countries have learned how to be better equipped. We're also seeing this in other countries, for example, in Congo and in other places in Africa. Countries are actually doing pretty well in terms of surveillance because of the Ebola epidemics that have occurred. Issue in more the political economic context, which and also the regulatory context, which influences the response, is the role of privacy and privacy laws. Privacy laws differs across countries, and this makes it easier or difficult to do things such as notifications across phones, determining that you may have been in contact with an individual who has COVID-19, et cetera. A mirror of that is in terms of public health regulations. Countries differ in terms of the teeth that their public regulations, health regulations have. In some countries, the public health regulations actually have a strong link with Ministry of Finance in the sense that a committee can make the determination and give the recommendation to finance to unlock contingency funds for epidemics. So that is one positive use of public health regulations of an emergency nature. These can also take the form of government actually having the capability of forcing private hospitals to address epidemic patients. Again, this is not necessarily written into law in every country, but it is something that is available in some countries in the region. The other factors which need to be considered are both Korea and China have the fiscal space to address the epidemic. Many countries are in the region do not have anywhere near this fiscal space. In terms of the short-term money, this is going to become more of an issue as we approach the medium and long term. As we know that GDP contracture, we're seeing 15, 20%, some countries even worse. And this is going to affect government revenue. This is going to affect Ministry of Health budgets. And we know that there are increasing fiscal demands through socioeconomic stabilization efforts, conditional cash transfer, small business loans. All of this is piling on already the COVID-19 response, which is already on the existing expenditures that a country may have. So we know that a country differs in terms of its access to short-term cash for COVID-19, but also in terms of what is going to be its debt structure. In 6 months to a year will be some very interesting observations around such and their ability to actually access debt. Debt in many lower income countries in terms of commercial debt is becoming scarcer and scarcer as investors flee to more stable environments. The also of importance is in terms of the economies of scale. Both China and Korea are fortunate in that they manufacture a lot of the test kits, a lot of the ventilators, a lot of the continuous positive airway pressure machines, the hemodialysis machines, et cetera. They have a cadre of well-trained people who are involved with intensive care unit management. Not every country has this, and some concerns for other countries is because it is a marketplace for ventilators and for test kits is getting access to them. You can imagine if you come from a smaller Pacific Island country, it's difficult for you to get access unless you're joining a joint purchasing arrangement for some of these scarce commodities. So that also needs to be taken into consideration. The role of the private sector that is pointed out professors. The issue of the private sector is very interesting in the region because there's so many different models of engagement, and also in terms of the setup of the private sector. We have lots of state-owned enterprises in the region, lots of them with very light touch with government, lots of them with a little bit more moderate touch from government. But the crucial point is, which Professor Kwan had mentioned earlier, there is an arrangement where the private sector hospitals already are involved with government through the social health insurance. It's mandated. It's not actually something that's voluntary. So you can work with the private sector very easily. This, again, is not available in every country in the region, where some countries is a bit more of a very light touch from government, and in other countries it's not. So an issue of concern for us in the Western Pacific Regional Office is in terms of essential care. We have great concerns. We know that COVID-19 is like a vacuum. In terms of the fiscal response, as well as in terms of clinical care, we know that patients are staying away from facilities. Partly this may be they're afraid to go to facilities. Partly it may be the services aren't being offered. But we're assuming there's going to be a great backlog of care, non-COVID related care, and this is going to have some fiscal consequences because a lot of these patients, cancer patients, chronic disease patients, are going to be later on in their disease course, so they're going to be more expensive to treat. That's it from our side. Over.
Thank you, Peter, very much for sharing your thoughts, and reflecting on the broader implications. And it's also great to hear that you're using these two countries as, learning for other countries. So we came in with a really relevant selection of countries for now. So now I have the pleasure of introducing Mr. from the International Labour Organization in Geneva. And I've asked her to perhaps reflect a bit on the social protection dimension of the crisis. So Lou, can I hand over the word to you?
Yes, I'll try to be short. I mean, thank you so much to the two presenters, because those were very interesting and rich presentations. I mean, I think from our side, what we're seeing is also a few characteristics that have come out in those presentations. First of all, of course, because we're a standards-based organization, it's interesting to see the importance of the rights-based frameworks in both cases and in both countries, and how that has influence on both the fact that you had already broad risk pooling mechanisms in each countries covering almost the entire population prior to the crisis, and how those could be mobilized to ensure that there wouldn't be financial barriers of access at the time of the crisis, but also how those can be mobilized to ensure that the private provision of care is aligned and maximize its benefits during this crisis. So I think that on this point of a rights-based framework, I think we also have to see how this evolves over the long run, and especially when it comes to possible issues of sustainability in financing of those broad risk pooling mechanisms that have been mentioned. And I joined the previous remark because we are getting more and more requests in terms of guidance from social health protection institutions in terms of the use of their technical reserves. And so I think that is something that is going to be an attention point in the forthcoming month. I think another important point that has come out of those two presentations is the complementarity or the need to look at cash benefits in times of sickness. And this is a bit where the coordination with the overall social protection system comes in, to make sure that the self-isolation and quarantine measures that are put in place are effectively implementable, and that they don't come at a net loss for the people who are impacted. And this kind of goes hand in hand with the necessity to have a continuum between this type of benefits that look very much at the situation of sickness, with, you know, broader measures of unemployment protection and cash benefits for vulnerable populations, because you know, we're looking at two countries that have already a number of mechanisms in place, but for a lot of countries that are being impacted by this virus, there is an important issue there, and that's where the component of really trying to have a coordinated approach across the health and social protection spectrum makes sense. So yes, and then I concur with a lot of the questions that are being asked, and I also happy to be able to ask them bilaterally to the presenters if at all possible in the future.
Thank you, Liu, for sharing insights from the International Labour Organizations, and also thanks for keeping to the time. So now the last discussants, we have the pleasure to have Eduardo Banzon, who's heading, you know, the health section in the Asian Development Bank, and the Asian Development Bank is, of course, also very engaged in the country's discussion, and thus I'm happy to have also someone from the regional bank now sharing his reflections. So over to you, Dodo.
What's interesting from a health financing perspective is how these two countries basically finance their response to COVID. If you look at South Korea, if you look at the Republic of Korea, and basically what happened there was sort of a local outbreak. It was a not national one. It was in a particular city south of Seoul, Daegu. And basically, in their approach, since they did not have the level of outbreak that we have in China, and of course, which you are also seeing now in a number of European countries, Italy, Spain, UK, and all of that, their focus was to control that outbreak so it doesn't become a national one. And one of the things they did is they paid for testing. Their national health insurance system basically paid for testing. They mobilized their private sector to be involved in testing. And if you saw the slide of Sunman, testing was basically done by the private sector. It's a very interesting way in which the country mobilized its financing system, which is national health insurance in Korea. And the way they have already engaged the private sector, and it's what Sunman said, the private sector is very much involved, required to be involved. In this case, the private sector part of the system, which is the companies making the diagnostics. And of course, now when we hear the story of Korea, it's a story of testing, of drive-through testing, of the ability to rapidly have an 8-hour turnaround of testing. And basically, and the way I look at it, it's a combination of course, great government policy, immediate action of a great Korean CDC, the national health insurance funding to it, and of course, a lot of our health pay for this outpatient diagnostic test, and of course, the private sector. Interestingly, in Asia right now, we're seeing so whether we talk about the Philippines now, we talk about India's PMJ, whether we talk about PCSK in Indonesia, a lot of the national health insurance programs now have for the PCR or the of COVID-19. There's also a lot of work now on bringing in the private its financing systems, including the private sector involved. Now let's go. In China, essentially, the outbreak is there. What was needed was how to respond. The cases were there. They to rapidly build up their from try to remember how more than 100 ECMO machines. They brought all over China to help out. They saw this as not just a economy of the country to the health system. They saw that if this outbreak was not yeah. So it's good. Okay. No. I I I I have a suspicion. Nonetheless, just to repeat, and so we're also to mobilize more money than we could use more money into health, and we're actually seeing this in Asia. So to summarize, it's I think okay, it's okay.
Okay.
So probably uh, I always say that WebEx, to summarize, as I said, they have was to control and outlet. They were able to use their national. In China, the cases were.
I assume everyone can hear me now. I hope. And yeah, I mean, thank you for confirming. So we have compiled the questions. There's no time to answer these. We will try to write them down as far as we can. And now, before we part, thanks again so much for the presenters and the discussions. I would like to hand over to the chair for closing remarks. So Irina, please, over to you. Irina Nikolic.
I can hear you.
Excellent. Thank you very much, Olivier, for your skillful facilitation. Thank you for our speakers, Professor Sunman Kwan and Professor Yingyao Chen, as well as our discussants, Peter, Lou, and Eduardo. I would like to just reflect on, even in this call itself, since we're in the throes of the current pandemic and we're still trying to address it, the importance of preparedness does not replace the need for learning on the go and decision making under uncertainty. I have heard today different strategies, but all around engaging broadly and purposefully with the society, other sectors, populations themselves, looking at those most vulnerable, long-term care, etc., those outside of the health systems, sort of best ability to reach them, and engagement with the private sector, use of technology and innovation, with multiple approaches to health financing. What I have also heard, and I would like to thank our audience for joining us in such large numbers, is great appetite to go both deeper on the elements of health financing, particularly around payment levels, mechanisms, how exactly one goes about insuring populations, making sure services are covered, details of benefit packages, long-term care financing, etc., as well as to go broader and to go outside of health sector and look at tech solutions that have enabled some of the areas of response. Unfortunately, we have not expected such a large audience and so many questions, and so we will find a way to address it. As the steering group member for the World Bank of P4H, which is our global network, please look at p4h.world to see today's presentations, and then Olivier will say a few words about how we might look to follow up, and we'll also put our thinking caps on and see how we might respond to many of the questions and also continue these series. Because I think, Olivier, thank you again for the initiative. I think this was really a terrific idea and an excellent way to start a date, at least here in America. Thank you.
Yeah, thank you, Irina, for your concluding remarks. And for some people, it may be an excellent, I hope, end of the day. And some will go now to sleep soon. Yeah, as Irina said, we will share the slides, certainly the recording of the session on the website of p4h.world. And we'll also try to find a way with the presenters to address at least some of your really rich questions. And we wanted to see how successful this is. I mean, certainly in terms of participation and engagement, I think we can call it a success. So we will continue certainly this series, and we have to see, which countries would become interesting in a next way, and also to start looking perhaps closer interconnection with low and mid-income countries to help them supporting reactions. So time is over. Thank you again so much for everyone. Thank you, Irina. Thank you, professors Sun-Man Kwon and Ying-Yan Chao. And thank you, dear discussants. And yeah, with this, I wish you a good day or good night or good afternoon. And take care, everyone. Stay safe, and we'll stay connected. Thank you.